Good evening, students. Can you all hear me? And are you all able to see the slides now? Could you please respond in the chat box if the audio as well as the video is very clear? Okay, thank you for your response. We'll start in a while. So, good evening, students. Welcoming you all to the final push series, which is an initiative which is going to really help you for your last minute preparations for your examinations. Okay. So let me introduce myself, Dr. Alina Babu, MDS in pediatrics as well as preventive dentistry. And I'm a consultant pediatric dentist. And also I have been giving lectures for various dental academies for Gulf traumatic examination preparations, as well as for, I've also been giving tuitions as well as MCQ preparations for various dental coaching centers. So it's my interest towards and my passion towards teaching that has led me here. So without any further ado, let us just start with the session. So requesting all the students to keep your audio as well as the video in mute so that there won't be any hassle during the classes. And if at all, if you face any glitch, just let me know through the chat box and we will be taking the necessary measures to correct it as well. Okay, so without any further ado, let's start with the final push. So let's start with the questionnaire. So just just for your knowledge, these are the previously asked questions, or these are the high yield question and answer discussion about which we would be dealing in today's session. So let's start by one. Okay, so just you can see the highlighted ones, which has been highlighted in this red color. So these are the important questions that has been asked. So a very main important tip to score better is that read the question properly, and once when you read it, try to chart the answer in such a way that your structure should be very good. Like, for example, just see the first question: define and classify the pulpotomy, discuss in detail the various materials used in pulpotomy and its advantages as well as the disadvantages. So when you're going to start your answer, it should be in a proper structure in such a way that you should have the definitions and introduction, and you should have all of this subcategories, whatever is being asked in this particular question. Okay, so if you attend the question and if you follow this particular method, it is it is going to be aesthetically pleasing for the examiner, and also it helps you in scoring better. Okay, so let's start with the first topic. So these are the different questions. We'll be discussing the very important high yielding questions. So we have 10 questions today, which I have prepared for you. So it is quite a challenge, both for me as well as for you as well. So within a short span of time, we have to discuss these many questions. So requesting all of your very good listening and also a happy learning to you all. So let's start with the pulpotomy, which is quite an important topic for your long essay. So let's start with the definition. So once again, can someone just let me know through the chat session whether my audio as well as my video, is it clear?
Yes, ma'am.
Okay, thank you so much. So let's start with the definition of pulpotomy. As I told, the correct structure, or how well you chart the answer, that is a very important point when it comes towards scoring for, or when it comes towards getting a good score for the examination. So the definition of pulpotomy is that it is defined as the complete removal of the coronal portion. So that is what is very important of the dental pulp, followed by the placement of a suitable dressing or a medicament that will promote healing, and also it will preserve the vitality of the tooth. And as an adjunct, you can also provide the AAPD, that is the American Association of Pediatric Dentistry, has defined pulpotomy as the amputation, that is nothing but the searing off or the cutting off infected coronal portion of the dental pulp, preserving the vitality and the function of the remaining part of the radicular pulp. Now coming on into the objectives. So as I told, just go through the substructures, or just go through the questions, what they have asked, and accordingly you make the subheadings. So talking about the objectives of pulpotomy, the radicular pulp should remain asymptomatic and no postoperative radiographic evidence of pathologic external root resorption should be present, and an internal root resorption may be self-limiting as well as stable. Coming on to the rationale, or what is the need for you to conduct the pulpotomy. So the radicular pulp is healthy and capable of healing after the surgical amputation. It preserves the vitality of the radicular pulp and it maintains the tooth in a physiologic condition. Okay, so these are the rationale for which we conduct the pulpotomy. Now coming on into the indications. Okay, so whenever you're writing the question, just like how I told regarding charting, same way, just make some particular mnemonics that will actually help you whenever it comes towards all of this important questions. Make a particular mnemonics and chart your answer in such a way that you don't even miss even a single important point from all of this. So to start with the indications, for your better understanding, I had put up a few interesting pictures as well. Okay, just like how the first picture shows a vital tooth with healthy periodontium, and then the pain should neither be spontaneous nor persisting, and you should find that the hemorrhage is pale red and the bleeding should be easy to control. And then most importantly, the tooth should be restaurable, and the tooth in which we are going to attempt pulpotomy should have a minimum of 2/3 of its root length. Now coming on into the contraindications. Contraindications is also as important as the indications, okay? So these are the conditions where you are not supposed to do the pulpotomy. In that, we have the conditions like internal resorption, abscesses or fistula, calcification of the pulp, interradicular bone loss, caries penetrating the floor of the pulp chamber, and the tooth that is close to natural exfoliation. Okay, so the moment you write such questions, or whenever you get a question of pulpotomy in your exam, just try to recall whatever has been taught in this class. Just try to understand. By the time you are done with this session, you should have at least a few take-home messages. So that is the entire reason why we have been conducting all of this revision series. Okay, so just have a quick look on all of these. Getting on into the yet another important part of pulpotomy, the classification. So broadly, it is classified as vital pulpotomy techniques, in which we have the devitalization techniques, preservation, as well as the regeneration techniques. And in non-vital pulpotomy techniques, we have the ones which we use beechwood cresol, as well as the formacresol. Yeah. Now getting on in, or as a part of the question was to define as well as to classify the pulpotomy and to enumerate the different materials that we use for the same. So talking about the devitalization kind of pulpotomy, which is also called as mummification or cauterization, for which we have the different agents like formacresol, paraffin paste, as well as the electrosurgery. Talking about the preservation or minimal devitalization or non-inductive procedure. In that, the different materials which we use for pulpotomy is zinc oxide eugenol, glutaraldehyde, as well as the ferric sulfate. And then we have yet another method of vital pulpotomy, that is regeneration or inductive or reparative, as the heading suggests. So these are the different materials. Whatever is listed under this are the materials which helps in regeneration. As an example, we have calcium hydroxide, that is bond morphogenic proteins, biodentin, MTA, etc. Now coming on into the non-vital pulpotomy or the mortal pulpotomy. So a very common question that we get is like, pulpotomy is for vital tooth structure. So why do we have a non-vital pulpotomy as a category? In certain situations, probably when the tooth is non-vital, but you are not, ideally, you are supposed to do a pulpectomy for the same. But you are in a condition wherein you could see a few calcified canals, or the patient is so uncooperative in such a way that you cannot do the required procedure. So that is when we do the non-vital pulpotomy, for which the different agents which we use is beechwood cresol as well as the formacresol. Yeah, now getting on into the devitalization, for which we have the single sitting and the different agents which we use is formacresol, electrosurgery, as well as laser. And then we have the two-stage devitalization technique, in which the different materials that we use is Geisel paste, Easlix formaldehyde, and the paraform devitalizing paste. Okay, so just have an idea regarding each of this. As I told, give more importance to flow charts. So no lecturers or no examiners are so much or too much into all of this theory. It's all about how well you could present the answers. Just imagine, instead of this slide, just imagine that I'm just writing it as devitalization and I'm just writing it as paragraph. So obviously, the way, however, I'm writing in a paragraph would be quite boring when compared to whatever I have been present here, okay? So just give more importance to a proper charting in such a way that try to involve maximum flow charts in your answers. Yeah, now getting on into the single sitting pulpotomy, for which we'll start with the formacresol pulpotomy. So formacresol is an agent which has been formulated by Buckley in 1904, talking about the composition. So this is something which is very important from examination point of view. Yeah, so we have 19% of formaldehyde, 35% of cresol, 15% of glycerin, and 31% of water. Okay, so these are the important compositions that you are bound to know, and the current concept. So this is something which is very, very important. So we have a number of so we have a number of authors according to which the time of application of the same would change. The current concept that we follow now is 4 minutes of application time for the formacresol. Now getting on into the mechanism of action. So it mainly acts to the aldehyde group of the formaldehyde, and some very important point that you have to remember about formaldehyde is that it is a bactericidal and also a devitalizing agent. Now talking about the different 3 zones of fixation with progressive fibrosis. So as I told, when you're charting the answer, you should have all the adequate headings, or whatever has been asked in the questions should be well charted. Coming on into the 3 zones of fixation, we find the acidophilic zone of fixation, the broad pale staining zone with diminished cellular and fiber definition. And then we have a broad zone of inflammatory cells that is concentrated at the pale staining junction. So just have an idea regarding the same. Yeah, I hope you can see the image that has been given here. We have the different zones. Where I have kept the pointer currently is the zone of fixation. We have the zone of diminished cellular activity and the zone of inflammation, followed by which we have the vital tissue in its place. Yeah, so this is going to be the pharmacrosol pulpotomy procedure. As I told, give more importance towards the flow charts, and to enumerate, I would just like to enumerate this particular pulpotomy procedure where I have kept the pointer currently. That is, whereas when you're writing for the examination, you have to make sure that you write all of these points in detail. As I told, that particular hint to score better is always to write out the important points, put arrow marks, and then continue. So here I would be just enumerating the most important steps of this pharmacrosol pulpotomy procedure, for which once when you're done with the local anesthetic as well as a proper isolation, you have to go with the deroofing, and after that you have to go with the pulp amputation. Followed by that, the pharmacrosol should be moistened with cotton, which is applied against the exposed pulp tissue for a minimum of 5 minutes. As I told, the current concept is that we have to maintain it for a minimum of 4 minutes. Other than that, or the normal time that we would like to prefer keeping this pharmacrosol is 4 to 5 minutes. Okay, and followed by that, once when you get to know that once when you remove it, you check for the fixation, and whenever you could see a brownish discoloration of the pellet as well as the pulp stem is an indicator of fixation. That is when you have to go with the placement of zinc oxide eugenol paste, after which you go with the coronal laceration, and finally the stainless steel crown placement. Yeah, now getting on into the other methods of single sitting pulpotomy, we use electrosurgical pulpotomy. So as the name suggests, electrosurgical. So this is a method in which we are not using chemicals. Instead, we are using electrocautery mechanism in such a way that electrocautery carbonizes, and the heat denatures the pulp, and the bacterial contamination is being controlled. So that is what we are trying to get with this electrosurgical mode of pulpotomy. It's a non-chemical devitalization technique wherein we are using electrocautery. Okay, so I think it is evident in the picture that I have given here. Yeah, and after amputation of the coronal pulp, the pulp stems are cauterized through this method. Now coming on into the yet another method of single sitting pulpotomy is the laser pulpotomy. And one more hint that I would like to give you is that the moment you start writing the exam, first give more importance to whatever they have asked. And once when you're done with the important core, please make sure that you show up some information that you have regarding the recent aspects as well. So such a recent aspect is this laser pulpotomy, in which we use the different lasers like this Nd:YAG lasers, and there have been a considerate amount of clinical success as well as radiographic success for this Nd:YAG laser pulpotomy when compared to that with the pharmacrosol pulpotomy. Okay, so just have an idea regarding all of these. Yeah, now coming on into the two-stage vital pulpotomy techniques. So whatever we just discussed now, that is starting with the pharmacrosol pulpotomy, the electrocautery, as well as the laser, they were all the single sitting pulpotomy techniques. Now coming on into the two-stage, in which we use the materials like this Glycol paste, E-Slix paraformaldehyde paste, as well as the paraform devitalizing paste. So these are the different methods which we use for the same. And here the steps are same as that of the one appointment procedure. And the difference is that a cotton pellet moistened with diluted pharmacrosol is sealed into the chamber for a time period of 5 to 7 days with a durable temporary cement. And at the second visit, the temporary filling and the cotton pellet are removed, and the chamber is irrigated with the hydrogen peroxide. Followed by that, we go with the Sedo-based cement, as well as the tooth is restored with a stainless steel crown. Okay, so this is regarding the two-stage techniques. Now, talking about pulpotomy, you have to also know regarding this partial pulpotomy for traumatic procedures, which is nothing but the civet pulpotomy, which is indicated in the young permanent tooth. I hope you all remember, or I hope you all know what is a young permanent tooth. That is an immature tooth which is having an open apex, okay, where the root closure is not complete. So civet pulpotomy or partial pulpotomy is a particular method which has been indicated for this young permanent tooth, and the rationale is basically to preserve the vitality of the radicular pulp. Okay, so just have an idea regarding the same. Yes, so these are the different steps, just like how we studied previously. Start with the administration of LA as well as the isolation. Start with the caries removal, followed by that, make sure that you get the hemostasis. Followed by that, you have to place the calcium hydroxide as well as the intermediate restrictive material. Yeah, now getting on into the different materials that you would use in a preservation kind of pulpotomy, wherein you have the zinc oxide eugenol, and ZOE is acting as an obtundant in this particular zinc oxide eugenol preservation technique, but apparently it failed to suppress the metabolism adequately. And then we have another method or another material, that is the glutaraldehyde pulpotomy. So the toxic product should be fixed rather than treated. So that is the basic funda because of which we try doing this glutaraldehyde pulpotomy. And it is a bactericidal agent. And the mechanism of action is that it produces rapid surface fixation, and a narrow zone of eosinophilic, stained, and compressed fixed tissue is found directly beneath the area of application. Okay, so basically, this glutaraldehyde fixed zone is replaced by a macrophagic action with dense collagenous tissue. So whenever we are going with the newer materials, make sure that you give an introduction or probably a 2 sentences regarding the material, then just give out the mechanism of action of the material as well. Yeah. Then to continue with the ferric sulfate, in which we use 15.5% of ferric sulfate, and it is mainly the agglutination of these blood proteins results from the reaction of the blood with both ferric as well as the sulfate ions, and the agglutinated proteins form plugs to occlude the capillary surface orifices. So basically, we have a metal protein cloud that has been formed as a barrier. So that is what you have to understand in the case of this ferric sulfate. Yeah, so that was regarding pulpotomy. I hope you all have understood regarding the different materials that you have to use as well as the classification. Now to continue with the pulpectomy procedures. So let's start with the definition. Mathewson has defined it as the complete removal of necrotic pulp from the root canals of primary teeth and filling them with an inert resorbable material, which is very important, so as to maintain the tooth in a dental arch. And Finn has described pulpectomy as removal of all pulpal tissue from the coronal as well as the radicular portions of the tooth. So as I told, charted in such a way that you have all the headings that I've asked. So we are done with the definition. Now heading on into the objectives of pulpectomy technique: to maintain the tooth free of infection, biomechanically cleanse as well as to obturate the root canals, promote the physiologic root resorption, and to hold the space for the erupting permanent tooth. Now talking about the indications, a very important point or a very important area that you shouldn't miss from your examination point of view. So write the indications. So for pulpectomy, we have the general indications in which the patient should be in a good general health without any serious diseases, and you have to be, and the patient should have a maximum cooperation. Now coming on into the clinical indications, you have the indications like strategically important tooth. Only then you are bound to continue with the pulpectomy procedure. A previously planned tooth for pulpotomy that shows uncontrolled pulpal hemorrhage, indicated for any tooth in the absence of a successor. That is, in certain cases when you don't have a successor or a permanent tooth beneath it, such kind of tooth is an ideal indication for this pulpectomy. Any deciduous teeth with severe pulpal necrosis, provided there is no radiographic contraindication, and then primary teeth with necrotic pulps and minimum root resorption, primary teeth with an abscess or sinus opening, and then the traumatized teeth with fracture or caries involving the pulp. Now talking about the radiographic indications for the same: adequate periodontal and bone support, minimal periapical changes with insufficient bone support, at least 2/3 of the root length should be available, and the internal resorption without any perforation. Okay, so just having a very good idea regarding the indications. So always write it as general indications, clinical indications, as well as the radiographic indications. Heading on into the contraindications of pulpectomy, general is that young patient with systemic illness is a contraindication. Children on long-term corticosteroid therapy is also a contraindication. Starting with the clinical contraindications: excessive tooth mobility, communication between the roof of the pulp chamber and the region of the furcation, insufficient tooth structure to allow isolation by rubber dam and extracoronal restoration. Talking about the radiographic contraindications, we have the external root resorption, internal root resorption in the apical third, And in situations where we see the radicular cyst, dentigerous cyst, etc., and then the interradicular radiolucency that communicates with the gingival sulcus. Okay, so just have an idea regarding each of these. Yeah, now getting on into the steps as well as the details of the single visit pulpectomy. So it is probably indicated in large carious exposures with frank involvement of radicular pulp without any periapical changes. Okay, so you are bound to know which are the situations or what are the indications wherein you will do a single visit pulpectomy. And then another indication for the same is primary teeth with inflammation extending beyond the coronal pulp. And then teeth that exhibit clinical symptoms to heat or cold and not to percussion. So just have an idea regarding the indication. Yes, so to continue with the procedure, as I told, flow chart is something which is inevitable. Just have a look on all of these procedures. As I read the theory, just go through the pictures that is given here so that you will get a better idea. And always try to represent whatever you have been writing it out with simpler diagrams. Probably you can just draw a diagram in which you can see the placement of this files, and just make sure that you as an adjunct you have to give small pictorial representations which would be very easy for you in such a way that you don't consume so much of time as well. Okay, yeah, talking about the procedures, after proper anesthesia as well as isolation, the access cavity is prepared, the pulp chamber is de-roofed, and all the accessible radicular as well as the coronal pulp is removed using the broaches, and then followed by irrigation. We have to place a diagnostic file in which after which a radiograph is to be taken after the placement of a diagnostic file. Yes, and then the canals should be filled with the aim of enlarging them to permit condensation of root canal filling material. That is, a proper BMP has to be done. That is the biomechanical preparation. After that, flush out all the debris and the dentinal shavings with the help of irrigating solutions. Dry the canals with absorbent paper points. Obturate the tooth completely, sealing the coronal as well as the radicular portion. And then finally, place a final restoration. Also, support it with a stainless steel crown. So these are the method, or this is how you have to write the procedure. Now getting on into the multiple visit pulpectomy. So it's quite similar. All of the steps is quite similar, and it is indicated where an infection or an abscess or a chronic sinus exists, and in non-vital primary teeth and the teeth with necrotic pulp as well as a periapical involvement. Okay, getting on into the first appointment in which you have to go with the access opening. So as we just discussed previously, after proper anesthesia as well as isolation, go with the access cavity preparation and de-roofing of the pulp chamber, after which you have to remove all the accessible coronal and the radicular pulp tissue, followed by the placement of formocrosol cotton pellet, and a temporary restoration is done. Now getting on into the second appointment, that is for which you have to call up the patient for cleaning and shaping. So here the appointment should be in 5 to 7 days apart, and remove the temporary restoration and file the canals in such a way that you complete the BMP procedure here. Followed by that, determine the working length, irrigate the canals. Indication of complete BMP is smooth canals that have same shape as that of the external walls. Followed by that, irrigate and debride. Finally, dry the canals and place a temporary restoration and placing a sterile cotton pellet in its chamber. Now coming on to the third appointment, as we just told, it should be probably after 5 to 7 days. Remove the TF, irrigate and dry the canals, and start obturating. So the first, you have to coat the walls of the canal with a thin watery mix of the cement with the help of a reamer, and then you have to use the thick mix and fill the canals using lentillospirals, which is the ideal choice for filling the root canal filling material. And then keep on adding the fresh mix until there is no place in such a way that no files or no cements can be incorporated into the canals. Finally, you have to seal the chamber, recall after 1 week, and if the patient is asymptomatic, that is when you have to go with the final restoration and the SSC placement. Yeah, so as I told, always try to help your own explanation, or just try to put up all of this simple pictorial representation so that the examiner gets a very good idea that you are really aware about the procedures that is involved in the pulpectomy. Getting on into the criteria for an ideal pulpectomy obturant. So the material, whatever we have been using, should have the ability to be, it should be a resorbable material, antiseptic property, non-inflammatory and non-irritating to the underlying permanent tooth germ, radio opacity for visualization on the radiograph. It should have an ease of insertion and removal, and it should not cause any discoloration of the tooth structure. Talking about the obturation, so this is one particular mnemonic that can help you for writing the same. That is, the tooth that you're going to obturate should be asymptomatic and dry. There should be no evidence of sinus formation. It should have a negative culture, no odor, and also a intact temporary. Talking about the aim to prevent the recontamination and to isolate as well as to neutralize any residual bacteria. Yeah, so these are the different or the very common obturation materials in primary teeth, broadly classified as zinc oxide eugenol derivatives, calcium hydroxide, as well as the iodoform-based paste. So just have an idea regarding the different or a few examples which come under each of these different categories. Yeah, so for your ease of understanding, I have just put up a table so that you can know the components of each of this. Now talking about the obturation techniques. So you're also bound to know the different methods using how well you can obturate the root canal. So we have the pressure syringe method, lentulospiral method, injection. That is, it can be used via a disposable or a tuberculin syringe, condensation with moist cotton pellet, use of paper points, amalgam carrier, and also the pluggers. Yeah, someone has just asked to show the previous slide so that you could take a screenshot. Yes, so you can just, I hope you have taken a screenshot of the same. So as I told, it's quite a challenge to finish all of these questions in such a short span. Okay, so let's continue. Other than the lentulospiral as well as the injection methods, we also have condensation with moist cotton pellet, the use of paper points, use of amalgam carriers, as well as the pluggers. Okay, so this is regarding the obturation techniques. Yeah, now getting on into our third question, that is regarding the apexogenesis as well as the apexification. Quite an important point or quite an important question from your examination point of view. And I don't think many of you have a clear-cut idea regarding when to do apexogenesis as well as apexification. So please listen to the session. So apexogenesis is what we are going to start with. It is defined apexogenesis. It is defined as the treatment of a vital pulp in an immature tooth to permit continued root growth and apical closure. So, yeah, so just understand that apexogenesis is that particular methodology that you would use in a vital tooth and in an immature tooth, okay? Immature, as I already told, it is a particular tooth which is having an open apex, okay? Yeah, so it is a physiologic process and it is for which we are trying to help the formation of apex in a young permanent tooth. So that is regarding apexogenesis. So just have an idea regarding what is it. Basically, we are helping a vital pulp in an immature tooth to permit its continued root growth. Okay, we are just putting some materials in such a way that we are helping that particular tooth to continue its root growth on its own. Okay. Yeah, and talking about the rationale, the rootent development occurs in a tooth with a normal pulp and minimal inflammation, and the pulp of immature teeth has significant reparative potential. The pulp revascularization and repair occurs more efficiently in tooth with an open apex. So that is the reason why we are heading on with this apexogenesis. Now, talking about the goals, as I told, whenever you are writing the paper, make sure that you give all of the subheadings. So if you just imagine, you're getting a question like this, and the moment the examiner see your answers like this, it itself gives a very good idea for the examiner that the student whoever has written this answer has a very good idea regarding the subject, okay? Yeah, so the goals of apexogenesis, that is to attain a favorable crown and root ratio, to attain a root end closure, to preserve the pulp vitality so that it can help in further root development and maturation, and then generating a dentinal bridge at the site of pulpotomy. Now talking about indications, the pulp exposure due to caries or trauma, normal radiographic appearance, absence of sensitivity to percussion, no abnormal response to thermal stimuli, or little or if any evidence of intracoronal abscess formation. So these are the different indications wherein you will go with the apexogenesis and talking about the contraindication, that is clinical evidence of degenerative changes in the radicular pulp, avulsed and replanted or a severely luxated tooth, severe crown root fracture that requires intraradicular retention for the restoration, and the tooth with unfavorable horizontal root fracture. Let me just say, contraindications are equally important as indications as well. Okay, so this is a very important slide. Yeah, now getting on into the apexification. So it is defined as a method to induce the development of the root apex of an immature pulpless tooth. Okay, so this is something that you have to know. Pulpless, which means that it is a non-vital tooth, by the formation of osteocementum or a bone-like tissue. So basically, apexogenesis is for vital immature tooth and apexification is for immature pulpless tooth. Okay, so just have an idea regarding the same. Whenever there is no life or whenever it is dead, we have to go with the apexification procedure, wherein we are trying to put one external barrier and then we are trying to artificially close it. So that is, in simple terms, that is what is called as apexification. Yeah. Now talking about the objectives, to induce either closure of the open apical third of the root canal or the formation of an apical calcific barrier against which the obturation can be achieved. Okay, so probably due to trauma or due to caries, there comes a state wherein the tooth is completely dead and in such a way that the tooth cannot continue with the normal apexogenesis. So that is when you have to go with this apexification procedure. Basically, we are putting a barrier, okay? And it is indicated for teeth with open apices and thin dentinal walls in which the standard instrumentation techniques cannot create a apical stop. Getting on into the technique, the question that was asked previously was to enumerate the apexogenesis as well as apexification and then to write the technique in detail. Yeah, so we have to start with the access opening, the canal destination placement of this apical barrier, and the reinforcement of the canal. And the different materials, again, very important point that you have to keep in your mind. The different materials that we use for apexification is zinc oxide eugenol. And then we have the camphorated parachlorophenol, tricalcium phosphate, and a combination of beta, tricalcium phosphate, resorbable tricalcium phosphates, collagen calcium phosphate gel, calcium hydroxide, and the ones which we use very commonly are the derivatives like derivatives of calcium hydroxide, that is MTA or biodentin, etc. Okay, so just have an idea regarding the technique. Yeah, so this is just that we have given it in detail. Okay, so just go through all of these. So due to lack of time, I would be just reading it quite a little faster. Okay. After access opening, you have to determine the working length and in such a way that you give a very light filing force, because as we already told, the dentinal walls are very thin. And then a lower strength of NaOCl is used because of the increased danger of placing the agent through the apex in immature teeth. As I told, it's a case wherein you have an open apex because of which you have to be very careful regarding the same. And then the canal is dried with paper points and a creamy mix of calcium hydroxide is spun into the canal. Additional disinfecting action of calcium hydroxide is effective after its application for at least 1 week. So the continuation of the treatment can take place at any time after 1 week. Okay, so if you could notice here. So after doing the BMP and all of the necessary steps, we try to put in the calcium hydroxide or MTA or biodentin in such a way that by the time the patient comes back to us after 1 week or probably in the next upcoming weeks, you could see that there is a hard tissue barrier in such a way that even if we put the file, it does not get into the periapical region. Okay, so that is what we attain to get after this apexification procedure. Yeah, so this is the Frank's criteria for apexification. So basically, we want a closed apex through minimum recession of the canal or closed apex with no change in the root space, radiographically apparent calcific bridge at the apex, and there is no radiographic evidence of apical closure, but upon clinical instrumentation, there is definite stop at the apex, indicating that there is a calcific repair, as I just told, okay? Yeah, now getting on into the yet another important topic, that is behavior management. So we are done with the most importantly asked questions from this pediatric endodontics. Now getting on into the behavior management, quite a topic which is quite easy for you to understand. So let's start with the definition. We do have a different range of definitions for behavior shaping, modification, management, etc. So let's study what is behavior management. The means by which the dental health team efficiently and effectively perform the dental treatment and simultaneously instills a positive dental attitude in the child. Getting on into the objectives, you have to render the treatment effectively and efficiently to instill a positive attitude, to establish an effective communication, and to gain confidence of both child and the parent, as well as they should be in a condition to accept the treatment wholeheartedly, and then to provide a relaxing and a comfortable environment. Now getting on into the classification, as you know, it's a very broad topic. So here in this slides, I have enumerated the different classifications, and we will be dealing in detail regarding the communication along with the tell show do, that is a TSD technique, and also, and also I would be dealing with the home exercises, okay? That is the hand over mouth technique. To continue with the classification of the behavior management, broadly, we have the non-pharmacological approach and the pharmacological approach. In non-pharmacological approach, or very commonly called as the psychological approach, we have the communication, and then we have the behavior shaping or the modification, in which you are bound to know the desensitization technique, modeling, as well as the contingency management. Then we have the behavior management of children with disruptive behaviors, in which we go with the voice control and with the aversive conditioning, in which we have home as well as physical restraints. So just remember, home or this hand over mouth exercise is a method of aversive conditioning. And the other techniques that you're bound to know is the audio analgesia, biofeedback, hypnosis, humor, coping, as well as relaxation. So this is regarding the classification. Now, getting into the detail, as per the question, they had asked us to enumerate and also to write in detail regarding the communication. So we know the different types is verbal communication, that is by speech, and then we also have a non-verbal communication, that is mainly through the body language, through the eye contact, through the expression of feelings, etc. Okay, yeah, and then we also show the non-verbal communication through a mere touch or just giving a hug or a pat, etc. And then we have the third category, wherein we have both verbal as well as non-verbal modes of communication. Yeah, so the key point of communicative technique is to establish a very good communication. That is basically honesty of approach is very much important. Establishment of the communicator and the message that has been delivered should be very clear. Okay, so the establishment of the communicator is nothing but in specific areas, that is in the reception. The receptionist is the person who is supposed to interact with the child and not the dentist. Okay, so at each level, you have to go with that particular communicator according to the levels. Then talking about the euphemisms. So this was a very important question. Though we are giving importance to long essays, if you just study a long essay properly, one particular help that you're going to get is that you will automatically cover the short essays as well. Okay, so euphemisms is a very commonly asked question, wherein you are using a substitute for the for all of this dental terminologies. So as an example, I could just tell that rubber dam is called as a raincoat, or you could say that the rubber dam clamp is called as a tooth button, or alginate is called as a pudding, etc. Okay, so this is regarding euphemisms, a point that you shouldn't miss whenever you are writing about the communication. Yeah, now talking about the tell, show, do technique, or the TST, a technique that is given by Adelson. So talking about the tell, show, do, the indication is that you have to do the procedure in the first visit and preferably in the child about 3 years of age, and the subsequent visit when introducing a new dental procedure. And also you can do it, or it has been indicated in an apprehensive child. Now talking about the new alternatives, as I told, whenever you're writing, write in such a way that the most important and the core has been written. After that, always, sorry, always as an adjunct or as something new, you have to also give the newer technologies or the newer alternatives for the same. So other than this tell, show, do, recently what we follow is the ask, tell, ask, wherein we are asking regarding the feeling of the procedure, telling the procedure and asking again how it feels. Other than the tell should do, we also have a newer alternative, that is the tell play do. Okay, so just write it just like how I have given in this image. Just write down these alternatives as well. Yeah, now getting on into the home technique, which is introduced by Evangeline Jordan. The indications of home, as I told, exercise that is not very commonly practiced, but the indications being a healthy child who can understand, but who exhibits defiance and a hysterical behavior. And in children who are in between 3 to 6 years, a child who can understand simple verbal commands, which is a very important point, and children who are displaying a uncontrollable behavior. Contraindications: the child under 3 years of age, handicapped child or immature child or a frightened child, and the child who is having a physical, mental or any emotional handicapping conditions. Yeah. Now talking about the factors that are to be considered before applying the home technique is that not to be used as a routine procedure. Inform the parents about the procedure, and the consent of the parent is very important. We do have the several variations of home in which we have the HOMAR, that is hand over mouth with the airway unrestricted, hand over mouth and the nose and the airway restricted, towel held over the mouth only, dry towel held over the nose and mouth, and the wet towel held over the nose and mouth. As I told, as the question has been demanding us to write in detail regarding the home, you shouldn't miss all of these variations of home as well. Yeah, so what you see here in this image is the HOMAR technique in which the airway is restricted. Now getting on into yet another important question, that is the early childhood caries. As I told, just start with the definition. We have ECC, or the early childhood caries, which is defined as the presence of one or more decade. Decade means that it is a non-cavitated or a cavitated lesion, and missing, that is due to the caries or filled tooth surfaces in any primary teeth in a child who is under the age of 6. So this is that particular classification that you have to memorize and you have to write it down on your paper. Now talking about the severe ECC. Any sign of smooth surface caries in a child younger than 3 years of age, or from the ages of 3 through 5, one or more cavitated or missing or filled smooth surfaces in primary maxillary anterior teeth, or a decade missing or a filled score of greater than or equal to 4. That is in the age of 3, greater than or equal to 5, and the age 4, or greater than or equal to 6, that is in the age group of 5 surfaces, constitutes the severe kind of ECC. So just have an idea regarding the definition of ECC as well as the severe ECC. Yeah, so this is something that you can take a screenshot as well, because it is as important. The classification of early childhood caries as given by Wayne et al. In 1999. Yeah, so basically we have the type 1 ECC in which we have the mild to moderate lesions, and then we have the type 2 ECC in which we have the moderate to severe lesions, and type 3, which is severe ECC. So let's start with the tooth that is involved in the type 1 ECC, that is the molars and the incisors. Age is 2 to 5 years, and the cause is a combination of cariogenic semi-solid or a solid food and a lack of oral hygiene. And talking about the progress of type 1 ECC, number of affected teeth usually increases as the cariogenic challenge persists. Then talking about the type 2 ECC, in which we go with the moderate to severe type of ECC, in which the tooth involved is labiolingual carious lesion affecting the maxillary incisors with or without molar caries, depending on the age, and unaffected mandibular molars. Okay, so this is something that you have to keep in mind. And the age is that this type 2 ECC is seen soon after the first tooth erupt into its position. The cause being inappropriate use of feeding bottle or at-will breastfeeding. And the progress is, unless controlled, it may proceed into an advanced stage. Now coming on into the severe ECC, and it is where the carious lesions involve all of the teeth, including the mandibular molars. Okay, just because it is severe, it does not exclude or it does not leave any of the tooth from getting the caries. And the age in which we see the severe ECC is generally 3 to 5 years, and the cause is a combination of factors and also a poor oral hygiene. And the progress is generally rampant in nature, and it involves the immune tooth surfaces. Yeah, so this is regarding the nascent caries as well as the rampant caries, which forms the two important parts of this early childhood caries. Yeah, so this nursing caries is again a subdivision of rampant. That is how we could say, okay? So it's a specific form of rampant caries in which you can see that the mandibular incisors are not involved. So because of which it is called as the nursing caries. And it is very commonly seen in infants and toddlers, and it affects the primary dentition. And a specific pattern is seen, as I just told, mandibular incisors are not involved. Talking about the rampant caries, in which there is a acute widespread caries with early pulpal involvement of the teeth, which are usually immune to decay. And the age of occurrences is that it is seen in all of the ages, and both the primary and the permanent dentition has been involved in this rampant caries. And characteristic feature, this one is most important, surfaces considered immune to decay are involved. That is, even the mandibular incisors are affected in the case of this rampant caries. Yeah, so as I told, the early childhood caries is having a multifactorial etiology. As you could see, the primary risk factors that would be involved is I guess someone's audio is on. Could you please mute it so that it won't be disturbing for the other students as well? Just mute your audios, okay? Yeah. So talking about the early childhood caries, you can see that there's a multifactorial etiology which is involved in the same. Basically, the primary risk factors would be the ad libitum breastfeeding, which is nothing but at will breastfeeding. Along with that, we have the susceptible host or the teeth, microflora, the substrate or the diet in which we have the sucrose. And then we also have the time, which is a very important primary risk factor. Talking about the diet, the high sugar diet or feeding practices, as well as the nocturnal or the night breastfeeding are considered as a very common etiology of ECC. In environmental factors, we have the premature birth or the low birth weight, poor parental education, and the low socioeconomic status. And among the microorganisms or thinking about the microflora, the important factors that you have to consider is the saliva, the oral hygiene, as well as the maternal oral health. And talking about the teeth, that is the host, the lack of fluoride exposure, the genetic factors, or the enamel defects. So all of these constitutes the multifactorial etiology of early childhood caries. Yeah, so though we have multiple number of etiologies, the one which I would like to explain would be the host, that is nothing but the teeth. So hypomineralization or hypoplasia of the teeth increases the susceptibility of the teeth to caries. Thin enamel in the primary teeth. So that is one of the common reason why there would be a early spread of the lesions, and also the presence of this developmental growth. Talking about the microflora, Streptococcus mutans, which is considered as a principal organism to colonize the tooth once it erupts into the cavity, and it is transmitted to the infant's mouth, primarily to the mother. So if you could remember, we have vertical transmission, horizontal transmission, all of these are all a part of this microflora. And it is considered more virulent. The reason why mutant streptococci is considered the most virulent is because of its colonization of the teeth. It produces a large amount of acid, and it produces a large amount of extracellular polysaccharides as well. Okay, so just have an idea regarding the same. Yeah, talking about the microflora, one point that you shouldn't miss for the examination is this window of infectivity for the Streptococcus mutans. Okay, so it is Paige Caulfield who just enumerated who gave us or who studied about the window of infectivity. So the first window of infectivity is seen around, or the median age where we would see this first window of infectivity is around 26 months, and the range is 7 to 31 months. And the second window of infectivity is wherein you will see the increased susceptibility to all of these caries in the age group of 6 to 12 years. That is once when we have all of the permanent tooth that has been erupting. And the time span between the acquisition of Streptococcus mutans and the caries initiation is approximately studied to be 13 to 16 months. Okay, so just have an idea regarding the same. Yeah, now talking about the management part. So the question which is asked for the exam was to classify ECC and to give the different etiological factors and also the management. So the management aims at to manage all of this existing emergency institution of preventive procedures, arrest as well as to control the caries processes, and also restoration as well as rehabilitation. Getting on into the proper treatment of how to manage the ECC, the first visit is when you will have to go for the treatment of the lesion as well as the counseling of the parent. So this is where you could consider all of this indirect pulp capping or pulp therapy, which can be evaluated, draining of the abscesses if it's present, collection of the saliva. Basically, you have to determine the flow as well as the viscosity, and the x-rays are to be advised so that you could assess the condition of this succedaneous tooth. So this is regarding the first visit. Now getting on into the second visit. So it should be scheduled almost after 1 week after the first visit, and the analysis of a diet chart and expression of the disease process of the child teeth should be done, and basically isolate the sugar factors from the diet chart. So it itself is a very important topic. We have multiple number of strategies which you will have to go with whenever we are talking about the management of this ECC. So it is in the second visit that you have to go, you have to give the patient, you have to enumerate regarding the diet diary, that is isolating the sugar factors from the diet chart, control the sugar exposure by intelligent uses, reassess the restoration and redo if it is needed. Caries activity tests can be started and it should be repeated at monthly intervals. As I told, it is very common that whenever you see multiple points like this, you tend to get confused, but make sure that the moment you are writing down, there should be at least 2 to 3 points that you have to remember. Okay, so in the second visit, you can give importance towards this diet chart, reaccess of the restoration as well as the caries activity test. Now getting on into the third as well as the subsequent visits, in which you will have to go for restoring of the grossly decayed tooth, endodontic treatment, crowns, as well as review and recall after a time period of 3 months. Okay. Yeah, so this is a flow chart which could help you with the prevention of ECC. So it should be done at the community level, at a professional level, and also at the home care level. Okay, so just have an idea. The main reason, whatever the method of prevention or however we implement it, we have to control the transmission of this cariogenic bacteria. Now getting on into the space maintenance, which is yet another important question which has been asked multiple times. So let's start with the definition of a space retainer, or very commonly called as a space maintainer. It is that particular maintainer or that appliance which is placed when some arch length has been lost, only if the space remaining is still adequate for the unerupted permanent teeth. Coming on into the requirements, and let me just say this is something that you shouldn't miss whenever you're attempting such a question. It should maintain the desired proximal dimensions of the space. It should be functional. It should not interfere with the eruption of opposing tooth. It should not interfere with the eruption of the erupting tooth. Okay, so let me just explain. This is one particular topic that you shouldn't miss. Okay, so all of these are quite important, and then it should not interfere with the speech or mastication. It should be simple as well as strong. It should not impose excessive stress on the adjacent tooth. It should be easily cleansable, and the construction should be easy, and it should not restrict the normal growth as well as the function, which is very, very important from this as a very important requirement. Getting on into the classification of space maintainers, according to Raymond Citru, they have classified it as removable space maintainers, complete arch, in which we have the lingual arch as well as the extraoral anchorage, individual tooth space maintainer. And according to Hitchcock, we have the removable or the fixed or semi-fixed, with bands and without bands, functional or not, active or passive, and also the combinations above. Okay, so just have an idea regarding the classification. Now talking about the classification according to Hendrickson, in which we have the fixed space maintainer. We have further classification as class 1 and class 2, in which class 1 is further classified as functional and non-functional, in which we have the functional ones as pontic type and lingual arch, non-functional as bath type and low type. And in class 2, we have the cantilever type as well as the distal shoe type. And in removable, quite easy for you to remember, we just have the acrylic partial dentures. Okay, let me just give you or let me just remind you once again, flowchart is something which is very, very important. The moment you write it like this, it becomes quite easy for you and also for the examiner to check. Okay, so just have an idea regarding each of these classifications. Now, the question which was asked was regarding the lingual arch space maintainer, its advantages, indications and contraindications, and its procedure of how we make a lingual arch space maintainer. So it is a bilateral, fixed or a semi-fixed, non-functional passive as well as it is a non-functional passive arch space maintainer. It helps in holding the molar position distally and the incisor segment anteriorly. As you could see here, the advantages means it prevents the incisors from collapse, it prevents the space loss from deep bite or from the lingual pressures from these oral habits, and it preserves the primary canine space in such a way that it helps in maintaining the arch length. So please give more importance towards indications, that is maintenance of arch perimeter, premature bilateral loss of primary molars after the eruption of the permanent incisors. The point after the eruption of permanent incisors is very important, or else what happens like this can block the eruption of this permanent incisors. And then maintenance or prevention of this mandibular changes in the arch length, retention or stabilization of this mandibular anterior teeth. Talking about the contraindications, prior to eruption of permanent lower incisors, rampant caries, high plaque scores, poor patient cooperation, anterior or posterior crow's bite, and extreme mandibular crowding. Okay, so just have an idea regarding each of this. And talking about the construction part. So select the appropriate band and complete the arch impression. The impression should indicate the outlines of the molar bands. Okay, only then you can get a very, or only then your construction would be correct. And then stabilize the band with a sticky wax, followed by that pour the cast and draw the upplanes on the cast. So wire runs from the middle third of the molar bands along the gingival third of the primary molars, continues along the cingula of the incisors, and the wire should be passive and it should not interfere with the occlusion, with the tongue movements or with the erupting permanent teeth. Then solder the wire onto the bands. As you can see here, finally remove and polish the upplanes and go for a trial. Then talking about the different types, we do have the fixed lingual arch space maintainer, in which we solder the wire onto the band, and then we have the semi-fixed, that is ends of the arch wire is fitted into the tubes that are attached onto the lingual surfaces. The modifications, as I told, whenever you are writing, when you are writing the traditional part of whatever the question is, always go with the newer advances or the modifications. So we have the U loops that has been given in this lingual arch space maintainers, that is for space regaining. So it is very commonly called as the Hodge upplanes. And then they can be the provision of canine spurs to prevent the midline shift as well. Now getting on into the next question, which is very commonly asked regarding the stainless steel crowns, and the sub-questions from this particular stainless steel crowns is its composition, its classification, and the procedure in which you have to provide the same. Yeah. So stainless steel crowns, as you can see here, first is described by Angel, and the definition goes like this: defined as the prefabricated crown forms that are adapted to the individual teeth and cemented with a biocompatible luting agent. And they are often referred to as the chrome steel crowns. Talking about the composition, as I told, something which is very important and asked multiple times, we have the SSC, in which we have the iron, chromium, nickel, as well as the minor elements. So just have an idea regarding the important composition of each of this. Okay, so the percentage is something that is good if you could remember and if you could pen this down as well. Other than that, we also have the nickel-based chrome, in which the nickel is the major content, accounting for 76%, followed by chromium, iron, carbon, manganese, and also the silicon. Okay, so just have an idea regarding each of this. According to trimming, we have the stainless steel crowns, which are classified as untrimmed crowns, pre-trimmed crowns, as well as the pre-contoured crowns. Okay, so the untrimmed crowns, as you could see here, they are neither trimmed nor contoured. So these are the pre-trimmed crowns. As you can see, the straight and the non-contoured sides, which are festooned, and then we have the pre-contoured crowns, which are pre-contoured, and also they are festooned. Now getting on into the classification, according to the company, we have the Rocky Mountain type of SSCs, Unitech, 3M, Acunel, as well as the New Smile. According to the position, we have the anterior teeth, in which we have the Unitech and the 3M Co. And according to the position, we also have the SSCs for posterior teeth, in which we have the New Smile, etc. And according to the occlusal anatomy, we have different, or as you can see here, we have the Ion, in which there is a compact occlusal anatomy, Unitech, which is having the best occlusal anatomy, the Rocky Mountain, in which you could see a small occlusal surface, and then Ormaco, which is the smallest and least occlusally carved. So just have an idea regarding the broad classifications according to all of these different strategies. Getting on into the indications, so many of us often know that it has been given only after a pulp therapy. Other than that, the indications are like it can be used for space maintenance whenever there is extensive caries, extensive decalcification, rampant caries, recurrent caries after a pulp therapy in the cases of this enamel defects and in the presence of this fractured teeth, and also after or also in cases of severe bruxism. And the contraindications being in the tooth which is near to its exfoliation age in non-resorbable cases, wherein you could see the mobility, and in patients who are having nickel allergy, and whenever you have more than half of the root that is being resorbed. So these are the contraindications. Just give me a moment. Yeah, to continue with the clinical procedure that you have to follow, start with the evaluation of this pre-operative occlusion. Administer LA, place a rubber dam. You have to go with the crown selection, the tooth preparation, evaluation of the tooth preparation, crown adaptation, crown finishing and polishing, crown cementation, and also the post-operative instructions. And the different method of how you go with the pre-operative evaluation is by diagnostic cast, by midline correction, cusp fossa relationship bilaterally, canine dilation, and also by means of extrusion of this opposing teeth and by the mesial drifting of adjacent teeth. So just have an idea regarding all of these clinical procedures. Before you get into the details of all of this, it will be really beneficial if you could just list it out like this. So the three options of how we can go with the crown selection is measuring the mesodistal diameter of the tooth before the preparation, crown selection after the tooth preparation, and also the trial and error method. And the different factors that are being considered during the crown placement is adequate mesodistal diameter, occlusal anatomy, height of the crown, the primate spaces, and also the light resistance to seating or the snap fit. Talking about the different armamentarium or the instruments that you will have to use for the same. So we have the different pliers like Johnson's contouring plier, which is being used for contouring the occlusal as well as the middle third of the crown. The other pliers that you have to use is the Gordon plier, the crimping plier for marked gingival crimping, ball and socket plier for exaggerating the interproximal contour in open convex, Hough plier for flattening of this interproximal contour of the crown and bridge scissors for cutting excess material at the gingival third of the crown. Okay, so just have an idea regarding the armamentarium. And talking about the burrs, as I told, you have to be in a position to pen down all of this in simpler words, just like how I have shown here. Just pen down all of this. We have the different number burrs like 169L or 69L FG, tapered diamond FG burr, number 6 or number 8, greenstone, rubber wheel, as well as the wire brush. So getting on into the aims of tooth preparation is basically to provide a space for the placement of a stainless steel crown, to remove all of the caries and the irregularities, to have a sufficient tooth for retention of the crown. And these are the things we had already discussed. Go with the adequate LA administration in such a way that the patient won't have any sort of discomfort, adequate rubber dam placement, removal of the caries, and also the wedging techniques. I'm talking about the occlusal reduction that you have to maintain. The occlusal surface of the tooth should be reduced by almost 1.5 mm, maintaining its occlusal contour or until the tooth is out of its occlusion. And if much of the occlusal surface has already been lost to the caries, then the reference can be made to the marginal ridges of the neighboring teeth. Okay, so as simple as that, remember that you have to maintain, or the occlusal reduction that is advised is 1.5 mm. Okay, so just have an idea regarding the same. And talking about the proximal preparation, you have to provide a proper slices, and a bevel at an angle of 30 to 40 degrees removes the sharp cusp tips and creates a gentle slope in the occlusal third of the lingual as well as the buccal surfaces. These are the different methods of evaluation of this occlusal reduction. I guess someone's audio is on. Could you please mute it so that it won't be disturbing for the other students? Yeah. Evaluation of occlusal reduction is by using all of this fact sheet by Froster, is by visual examination, and you can also use a prop as given by or as advocated by Mathewson. And then talking about the buccal as well as the lingual preparation. So we do have different authors who have given a varying information regarding the same. But however, we recommend that a minimal or a no preparation is to be carried out in the case of this buccal and lingual sides of the tooth crown, unless there is a pronounced enamel convexity. Okay. Yeah, then talking about the finishing that you are bound to know is regarding the beveling, in which the line angles are beveled at an angle of 30 to 40 degrees. Round occlusobuccal and gingival surfaces remove the sharp cusp tips and no obstructed crown placement. And basically, rounding of all line angles are very much important. And now talking about the adaptation, try the crown onto the tooth, and the direction is always lingual to the buccal. And then you have to mark a scratch line and always cut 1 mm below width using the scissors, as you could see here, and then place the crown again. See for the blanching and then fix on to the tooth. Now, regarding the adaptation that you are bound to know is the principles for obtaining the optimal adaptation. So the crown length that you have to maintain is that it should be having a 1 mm length, or it should be gone inside the gingival in such a way that subgingivally you should have 1 mm and then extend slightly apical to the tooth's height of contour. So that is regarding the crown length. And then talking about the shape of these crowns. 1 second, just give me a moment. Yeah, talking about the principles for obtaining optimal adaptation. Let's continue with the shape of the crown's gingival margin. So as simple as that, this particular image which is given here will give you an idea. That is the concerned shape that you have to maintain in the case of the different molars as well as the surfaces. So the buccal gingival contour of a second primary molar is that you have to give a smile shape, as you could see here. And talking about the buccal gingival contour of a first primary molar, it is to be in a stretched out S. And in the case of this proximal surfaces, you should always give a frown shape. And the lingual contours is always smile in the case of the molars. Okay, so these are different principles as given by Spedding. If you could pen it down, it would be like an extra information, and you could also fetch good marks as well. Yeah, then to continue with the contouring of the crown, that is, the crown gets work hardened by manipulation and it becomes more retentive. Talking about the crimping of the crown, the uses of crimping are protection of the soft tissues, prevention of leakage of the cements, and also prevention of contamination, and also adequate retention is being obtained by a proper crimping. And the particular instrument or the plier that you have to use for the same is number 417 crimping plier. Now talking about the evaluation, how well do you evaluate it? Check with the explorer. If the margins are open, you have to go with the recrimping. If it is overextended, then you will have to start again. Always evaluate by taking a biping radiograph, which is ideal to check for the adaptation of the stainless steel crowns, and also check for the blanching. Yeah, so this is regarding the crown finishing and polishing. So if it is unpolished, there could be chances of accumulation of plaque and gingivitis, and there could be, or the particular instruments that you have to use the same should be used for the same should be the large greenstone, the rubber wheel, as well as the wire brush. Now talking about the crown cementation, as you know, the crown cementation was also a sub question of whatever the question that was asked for you. The cements which we very commonly use for the crown cementations are the ones which are listed here, of which the very common one which we use is the luting time of glass ionoma or the resin modified glass ionoma. Now these are the different crown cementation procedures that you're about to follow. Basically, place a gauze piece posteriorly to the tooth, and then the tooth as well as the crown are cleaned. Isolation is a very mandatory step. Place the cement in the crown to fill approximately 2/3. After the isolation, you have to go with the application of Vaseline to all of the contact areas. That is in such a way that whatever the crown earns when you are putting or trying onto it, you don't want to get it stuck, or you don't want any such problems related to the same. And then once when you apply the Vaseline to the contact areas, mix the luting cement until there is a string that has been formed. And then you have to cover, or you have to place the cement in such a way that 2/3 of the inner surface should be covered. Followed by that, say the crown, and the direction is something that you have to note it down. That is from the lingual to the buccal side. And the cement should be expressed out from the slides, and then ask the patient to chew in the centric occlusion. Okay. Yeah, now getting on into the topical fluids. Very important again, it has been asked multiple times. So just have an idea regarding the same. The topical fluoride. So the question that was asked was to enumerate regarding the different modes of topical fluoride administration, and also to write in detail about the APF gel. Okay, so quite an important topic. So basically what happens whenever we are applying a topical fluoride is that during the remineralization process, the fluoride that is present in the oral environment gets incorporated into the tooth surface, and it forms the fluorapatite. And this fluorapatite is way more stable and resistant, or we can say that it is even more resistant when compared to that of the hydroxyapatite. Okay, the indications, as I told, always the indications and the methodologies is a very inevitable part of your way of answering, or it is a very inevitable part. Okay, so the indications is in caries active individuals, children who are shortly after the periods of tooth eruption, medication to reduce the salivary flow, or who have undergone the head as well as the neck radiation, after periodontal surgery when the roots of the teeth have been exposed, patients with fixed or removable processes, and after the placement or replacement of the restorations, patients with an eating disorder, or who are having a change in the lifestyle, and then mentally or physically challenged individuals. Yeah, so this is something which you could really be helpful for you to understand. The professionally applied topical agents or the topical fluorides are the neutrum sodium fluoride, stannous fluoride, the APF solution gels, and the varnish. And the self-applied are the dentifrices, the mouthwashes, as well as the fluoride gels. So though we have a number of topical fluorides, the one which is very important from examination point of view is the acetylated phosphate fluoride. So it is introduced by Brody-Wald, because of which the technique of application is also called as the Brody-Wald techniques of application. So the method of preparation is that an aqueous solution of this APF is prepared by dissolving 20 grams of sodium fluoride in 1 liter of 0.1 molar phosphoric acid, and then 50% of hydrofluoric acid is added to adjust the pH at 3. And then the fluoride ion concentration is adjusted at 1.23%. And this particular composition or this particular solution is what is called as the Brody-Wald solution. Talking about the mechanism of action, the APF applied, and it initially leads to the dehydration and the shrinkage of this hydroxyapatite crystals, and it undergoes hydrolysis, because of which there would be the formation of dicalcium phosphate dihydrate, which is a highly reactive element with fluoride ion. And thus the fluoride penetrates into the crystals deeply to the openings produced by the shrinkage, and it leads to the formation of fluorapatite. So let it be any mode of fluoride application, the entire idea or what we want to get ultimately is the fluorapatite. As I just discussed previously, fluorapatite is more stable and resistant to the acid demineralization. Just have an idea regarding the same. Yeah, talking about the procedure for application, the Brody-Wald technique, the patient is seated in the upright position. Once when the oral prophylaxis is done, the clinical application is done by the thread technique. The minimum amount of fluoride gel that is to be covered is less than, the gel that is to be covered in the tooth surface should be less than 5 ml. The gel thins out under the biting force. Okay, so this is what we call as the thixotropic property. So you have to place it in the mouth for almost 4 minutes, and then the patient is instructed not to eat or drink or rinse his mouth for a minimum of 30 minutes. Okay, so just have an idea regarding the same. This is how you have to write the procedure exactly. Okay, so as I told, nobody wants all of this bulky answers, and nobody actually gives importance, so nobody is ready to read all of this. Just try to make it legible and always try to get an impression in such a way that the examiner who is just evaluating your paper without even seeing you, just because the sight of the paper should give him an idea that you know a few topic, or you know a few important methods, or the few important signs that you have to know regarding each of this, whatever has been asked. Okay, so that is the basic reason why I'm asking you to maintain always flow charts and also pictorial representations, which are quite simple. Yeah, then talking about the advantages, it requires only 2 applications in a year, and the gel preparation can be self-applied, and the cost of application also gets reduced. It has the ability to deposit fluoride in the enamel, and it is a very stable solution. So disadvantages being the practical difficulties, like the teeth should be kept wet for 4 minutes, and it is an acidic solution because of which it would be sour in taste and also bitter. Now coming on about the pit and fissure sealants, which is yet another commonly asked question. So before getting on to the definition of the pit and fissure, let's see what are the pit. So they are defined as a small pinpoint depressions, as you could see here, located at the junction of developmental grooves or at the terminals of these. And then we have the fissures, which are basically the deep clefts between the adjoining cusps, as you could see. And the main reason why we have the pit and fissures, or what are the reasons why there are often caries that is very common to them, is because they are impossible to clean and they are very susceptible to the caries. And they occur on occlusal surfaces of the molars and premolars, and they also provide areas for retention of these caries producing agents. Talking about the definition, or what is a pit and fissure sealant: material that is introduced into the occlusal pits and fissures of carie susceptible teeth, thus forming a micromechanically bonded protective layer, cutting the access of caries producing bacteria from their source of nutrients. The type of fissures as given by NACO is that we have the V type, as you could see here, as I'm running the pointer. Just have a look here. Okay, so we have the V type fissure, U type fissure, K type, I type, as well as the inverted Y type of fissure. Okay, so just have an idea regarding the types. Yeah, so as I told, if they are asking about a particular material, whatever we have been using, let it be about an obturating material, or if they're asking about sealant material, always make sure that you have a heading which is the ideal requisites of that particular material. Okay, so the ideal requisites of an efficient sealant is that it should have a viscosity in such a way that it should allow penetration into the deep as well as the narrow fissures. So it should have a very good viscosity to allow penetration, adequate working time, rapid cure, good and prolonged adhesion to the enamel, low sorption and resolubility, the resistance to wear, minimum irritation to the tissues, and also the karyostatic action. Now talking about the type of sealants that you're bound to know, based on polymerization method, we have the sealants which are classified from 1st to 4th generations. Based on the filler content, we have the unfilled sealants, which actually gives a better flow. And then we have the semi-filled pit and fissure sealants, which are strong and resistant to wear. Based on color, we have the tinted ones, that is for easy identification. Clear pit and fissure sealants, which are difficult to detect. Opaque for easy identification again. And pink, which has a better fluoride release. Yes, so this was also a sub-question which is asked the factors which affects the sealant retention. That is the type of sealant, the position of the teeth in the mouth, clinical skill of the operator, the age of the child, and also the eruption status of the teeth. Yeah, so this particular area where I'm running the pointer is very important. The age ranges for sealer application. So though we have, whenever we study multiple number of questions, that is, as you know, it's a culmination of many topics. So you tend to get confused with all of this age ranges, but probably to score better, just make a note of this. The age ranges for sealant application is 3 to 4 years, that is the age when the primary molar sealant is to be placed. 6 to 7 years, that is when the permanent first molar erupt into its position. And 11 to 13 years, that is when the second permanent molars as well as the premolars are to be coated using a pit and fissure sealant. So just have an idea regarding the same. Now getting on into the last topic of today's session, that is the preventive resin restorations. So PRR. So many of you have a doubt regarding what is the difference between PRR as well as a pit and fissure sealant. So basically, you can say that the preventive resin restorations are a natural extension of whatever we just learned now, that is the pit and fissure or the occlusal sealants. It's a conservative answer to the conventional extension for prevention philosophy. So earlier, instead of, or if we want to control the caries progression, we would go with the extension for prevention. But now we have different minimally invasive techniques which follows the rule of prevention of extension. Okay, so PRR is one such method in which we are going to prevent the extension of cavity cutting. According to Simonson, it is classified as type A, in which we have the suspicious pits and fissures, where the caries removal is limited to the enamel and the local anesthesia is not required, and a slow speed, that is half round burr, is used to remove the decalcified enamel. And then we have the type 2, according to Simonson, in which the incipient lesions in dentin that is small and confined. And there is no local anesthesia that is required whenever we are going with the preventive resin restoration of type B. And an appropriate base is placed in areas of dentin exposure. Composite resin is placed and the remaining pit and fissure are covered using a sealant. And then we have the type C, in which you could see a more extensive dentinal involvement, and it requires restorations with posterior composite material, and an appropriate base is placed over the dentin, and the pit and fissures are covered using a sealant as well. And here local anesthesia is required. As you could see, it is a more extensive lesion with the dentin involvement. Okay, so this is regarding the classification by Simonson. Once again, we have the type A, type B, and type C. So one particular hint that I could just tell as a last note is that though you have a number of, whenever you have to write a number of points, the one which is more important is something, and the moment you are confident about whatever you're writing is correct, that is when you can also underline, or you can just highlight it, just like how I have done. Okay, so this itself give an idea that the examiner, whoever is checking, will just run his eyes to the important points that has been highlighted. Okay, and remember to do it once only if you're confident that whatever you have been writing is legible and true, correct. Yeah. Talking about the procedure for the preventive resin restoration. So the tooth is isolated and re-examined to determine the extent of caries process, and a number 329 burr aluminum oxide air abrasion or a laser can be used to remove the caries, and then a cavity and the enamel beside the susceptible groove are etched using a 37% of phosphoric acid for a time period of 20 seconds. And here the tooth is thoroughly rinsed for a minimum of 30 to 40 seconds, and then it is dried completely. A thin layer of bonding agent is applied, and then finally the cavity is filled with composites and the resin modified GIC. So this is a very important procedure. As I told, just imagine you're writing the same procedures as a paragraph. It becomes quite boring, and because of which the ideal method of how you have to write whenever it comes towards the procedures, let it be pulpotomy, pulpectomy, or apexogenesis, make sure that you just put a arrow, and this flowchart itself should help you to give a very good idea regarding whatever is being asked. Yeah, so these are the different references. Probably it will give an additional benefit if you could just write the reference. So as I told, always write the answers, or structure is very important when it comes towards how well you answer the question. Just you should have an introduction, the content in such a way that all of the sub questions, whatever has been a part of the question, is to be dealt, and finally come with the conclusion. So that's it for the class. Thank you so much for your time, and wishing you all the best for your very good preparations. Okay, thank you. You may leave the group now. If there is anything to talk, or if you want to let me know something, just let me know through the chat box.